Hello everyone. This is an introduction to the Protect Your Joints theme, as well as the first part of my shoulder case study, so it's pretty long. Please use the skip ahead buttons if you don't want to watch it all, and don't forget the credits and outtakes at the end, which are probably the best part of the whole video. We've got lots in store for this video blog, and you can expect that future episodes will be much more compact and lots better. Have fun watching. Hi, my name's Matt Barton. I'm a chiropractor practicing in Southwest Germany for the last 12-13 years, and I'd like to welcome you to Protect Your Joints. This blog is about joint dysfunction and also about how joint dysfunction can progress to degenerative changes in that adverse loads on the joints will inevitably cause damage and degeneration. So if we can decrease those dysfunctions and keep those harmful loads from getting to the joint or reduce them, then we can theoretically prevent or at least slow down degenerative joint changes. Very near and dear to my heart is the subject of injury prevention for everybody, but especially for young therapists, young clinicians, whether they be chiropractors, osteopaths, physical therapists, or massage therapists, that we really emphasize the value of prevention and ensuring that the loads on your joints are not going to adversely affect your health. I've been planning to do this blog for several years now because I feel that it's very important that my patients understand what joint dysfunction is, what nervous system dysfunction is, and how it's treated, and that the secret to long-term treatment success is really that understanding. Originally, I planned to do these blog segments in small case studies. That's still the plan. What's new is that I'm up first, and I'll get to that in a minute. We're going to be talking about joint dysfunction and how it can be the cause or also the result of dysfunction in the nervous system. We are going to be talking about how we treat joint dysfunctions, how we adjust, what we accomplish with that. We're going to be talking about how we treat repetitive stress and repetitive strain injuries, fibrosis in muscles and tendons, and how we combine that with rehabilitation, therapeutic exercise for the best all-around package for our patients. We're going to be dealing with topics from your day-to-day life. We're going to be dealing with the loads on your neuromusculoskeletal system through your work, through your free time and sporting activities. We're going to be talking about nutrition and genetics. We're going to be dealing with topics like stress and burnout or depression and how they interact with or cause problems in the neuromusculoskeletal system. So, for this blog, there are a few core principles that we're always going to come back to and reinforce. The first one is never break the roll slide rule. The second is cartilage is pain insensitive. And the third one is an arthrosis is for keeps. So we're going to be doing my case study a little bit out of order because I'm short on time, and we want to get some of the physical exam findings documented before the operation. And we're going to do things a little bit out of order in that we are going to do the history and really flesh out some of the important details. Then after the fact, we're jumping ahead right now to physical exam findings and the imaging findings. So I'm just going to give a quick rundown of the current situation. I haven't been working for several months now because the pain got so intense on my long days when I did double shifts, mornings and afternoons, that I really was not sleeping anymore. And there weren't many treatments that didn't cause intense pain. Long story short, I had to step out of patient care because it was starting to very adversely affect my overall health. Essentially, the situation is right now that the whole shoulder girdle, the parascapular muscles, the rotator cuff, all of my scapular elevators are in a constant spasm, and there are contractures that have built up both in the rotator cuff and in the infrascapular muscles. There's a very significant scapular restriction that I just cannot get rid of. The pain patterns have changed over the weeks and months. We'll get to that in the history in later episodes, but right now, essentially, every movement above about 70 or 80 degrees is associated with pain. The most problematic motions and loadings are taking place in abduction, horizontal flexion, and internal rotation. And that's actually the range where the crepitus, which was the first initial symptom, pain-free crepitus, just light grinding noises, way back when the whole thing started, has evolved into a very loud noise that people a couple of meters away can hear. Smaller accessory movements, tying shoes, picking an object up off the floor, cause twinges and shooting pains in the posterior joint, posterior aspect of the joint, and it's really loading dependent. The more I do, the more it hurts, and the less I sleep. So the best thing is that we have a listen for these joint sounds and do some physical exam findings, at least range of motion. So let's have a listen to those joint noises and do the range of motion and see how things look. I've adapted a microphone to tape to the front of my shoulder here so that I can hear the crepitus even when it's at a very low level, and thereby can do low risk scapular range of motion exercises without irritating the joint, in that as soon as I hear even a little bit of grinding, then I just leave that accessory motion alone, and it doesn't seem to irritate the joint when I do it that way. So the most problematic positions, movements, loads are in abduction, abduction with horizontal flexion and internal rotation. So let's do a range of motion. So abduction, pain starts about here, and that's the end. This side is free. This side is absolute stop. The rotator cuff and infrascapular muscles are all so contracted that there is absolutely no way of getting my arm any further. Flexion. There's pain. This one goes all the way, and that's the absolute end. So obviously, internal rotation is very much restricted, and external rotation. So the more I do range of motion, the looser it gets. I can get to the point where the arm will almost come all the way up in all ranges of motion. The problem is I pay for that after the fact. One or two exams that I had where the doctor pushed it to end range multiple times to test it, resulted in very little sleep on the night of the exam. So that was it for joint auscultation and the physical exam findings. Let's have a look at the MRI. So, welcome to the inside of my shoulder, or I should say, an MRI of the inside of my shoulder. Advanced diagnostic imaging modalities like MRI, and computed tomography are fantastic for all that they tell us about the inside of the human body. But we have to remember what they can't tell us, which conclusions we can make and which conclusions we can't make based on the images that we see. Those conclusions are going to affect our treatment decisions, and so in that respect we need to know the truths they tell us and the things they don't tell us. So the possibilities of diagnostic imaging, what it can and what it can't do, is always a very interesting topic, and we're going to be revisiting that a little bit in all of the case studies that we do, in this case starting with me. And so let's get to it. For those of you who are not familiar with magnetic resonance images, these are slice images. We don't see through the entire patient like with an x-ray, and everything's in gray tones. In these pulse sequences, water is bright and things that are not water are dark. So this viewer is not a professional medical diagnostic viewer, so we're not going to have the same resolution that we have in the doctor's office. When I look at the problem areas in this study here on my computer, they don't look half as bad as they did on the high resolution monitor with the good software, but we'll just make do with this, what we have. We can definitely see the problems as they are. So the way this works is, on the left we have this yellow cursor, and it tells us where the right panel is looking. So when I scroll through, then I can orient on exactly where I am and see what I want to see. So let's look at the first problem area, and frankly what most of the surgeons that I consulted think is the major problem, and that's this spot right here. You can see my red cursor there. I'm sort of highlighting the area where the problem is. So if we pick another slice and we look at how smooth and uniform those edges are, and then when we get into the problem area, we're seeing that this border where the cartilage meets the bone and vice versa is no longer clear and smoothly defined. That suggests that the cartilage is rough there. It's lost its smooth, slippery surface quality and is degenerating. So, and we can also see, I don't know if you can see this, but there's a bone spur forming on the underside of the edge of the head of the humerus here, and that suggests that the lesion is bipolar, that the cartilage on both sides of the joint may be damaged, and if that's the case, then it's going to negatively affect the prognosis. But we won't know that until we go in and operate, or the surgeon goes in and operates. And that's one of the realities of advanced imaging, is that it doesn't tell us everything. 5 out of 6 surgeons that I spoke to said they never rely fully, or they rely very little on these images. They're just a help to orient and direct the surgical procedure, or at least provide the indication for it. So that's one problem, and associated with that we have another finding that's pretty telling. This white area here, this bloom of high signal of bright white, is bone edema. That is a stress reaction. That's fluid that's not supposed to be there. That's a high signal in an area that's not supposed to have that much water. That's a stress reaction. It's bone edema, and that is indicative of the bone here is being subjected to more mechanical stress than it should be, and hence the bone edema. So that's another pretty clear finding. When we scroll down through, we'll see on the front aspect of the shoulder, this is the labrum. Knees have meniscus. The hip and the shoulder have labra. And here we see where the red pointer is, where the front part of the labrum is intact and it's meeting up with the bone here. And then we look at the posterior, the back part of the labrum, and it's somewhat separated, not completely intact or joined with the edge of the bone. So that's also a potential source of pain and instability and more degeneration. So we'll go ahead and look at the next problem area. As I scroll through here, you're seeing a lot of white, a lot of fluid, a lot of effusion. This is basically just too much joint fluid, and that's a product of inflammation. That's a product of the irritation that the joint's undergoing. So there's just too much fluid there. But one thing that everybody jumps on when they open these images is this hunk of something next to my biceps tendon. This black spot, tendons, ligaments, and cortical bone are dark. This is my biceps tendon. And whatever this is next to it is a free, loose body inside the joint. Where it came from, we haven't got a clue. There is no place in the surface of the joint that's lost enough cartilage to account for this hunk of whatever it is. A couple of doctors have said that this is possibly just an aggregate where cells just get knocked loose from the joint surface and then just start growing and making cartilage out in the joint, floating around in space, so to say. I'm very interested to see what he pulls out of my joint. We'll just have to wait and see. At any rate, I have absolutely and have never had any symptoms that are even remotely associated with the biceps tendon. So this was a big mystery to me when I saw it, because I could do biceps curls right now if I wanted to all day long, and it doesn't irritate the joint. So, last but not least, relevant or not for the current problem, is the AC acromioclavicular joint. That is the joint between the collarbone, which we're seeing here, and the spoon-like process, the acromion of the scapula of the shoulder blade. So, and we're seeing the joint diagonally, we're going through the joint diagonally here. And what we can gather from the acromioclavicular joint is that there is an effusion there. There is some bone spur formation, hypertrophy. The bone is reacting to stress and building more bone material up around the edges of the joint. Those are bone spurs. It's a common characteristic of arthritic changes, degenerative joint disease at least. So what we're seeing here is that it's putting a little bit of pressure, looks like, on the supraspinatus tendon. But it's not the worst that I've seen, and there's some doubt as to whether or not this is really part of my pain problem. We're going to be doing an injection test the day before the surgery. We're going to anesthetize this joint with a local anesthetic, and then we're going to look and see what the pain, how the pain symptomatic reacts, and that's going to tell us how relevant this is, at least what the pain's concerned on. So we'll talk more about that when we get to the operation itself.
Darling, all these things are true. She told me she can't wait to find you. What's it gonna take to make you see? What's it gonna take for you to believe me that I'm deep inside the part that never dies, the part that still believes in a life of danger?
innerhalb den Körper abgeht. Hey Arthur, was geht ab? Ein Kernspintomogramm von der Innenseite meiner Schulter. Hier. Möglichkeiten. Willkommen in eine. Habe ich das in den anderen gesagt? Okay. Gibt patients that are willing, interact, blah blah blah, blah 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 blah. All of the types of problems of the neuromusculoskeletal. Yeah, laugh it up. Joint dysfunction and nervous system. Talking about the loads and stresses. Work habits, we're going to be talking about, I should really have a script, or be the result of nervous system. That was the best one, I stuttered. We're going to be talking behandeln, viel sagen wir würden viel sagen. Occur in the joints, blah blah blah. I need a script. Orientieren, eigenen Gelenken. Helfe. And overall health. And blah blah blah. Crucial. Hello? Crucial. Nicht wichtig, mehr als wichtig. Blog-Etappen, Ausgaben. Beiträge. Besuchen würden. Behandeln würden. Erwähnen würden. Einige, was habe ich gesagt? Prinzipien. Depression, burnout, from your day-to-day life, you depressed bastard, you. Wait, guys. Be right back.